most you all know, right? Yeah.
Good morning, everyone. So we have a number of written questions, which is good. It'll keep me in the channel so I don't wander off. There's some ones that came during the week and some just very recent that I haven't even seen. So I like the ones I haven't seen because I can really improvise.
Dr. Juan, if you could speak up a little, please.
Oh, can you hear me? Is that better? Okay. So the first question, when I go to my neurologist, a series of dexterity tests are done. Finger tapping, heel tapping, my finger to his, then my nose and back, elbows tight at my side, arms out, palms up, and I rapidly flip them, palm up and down, and so forth. How are these tests scored, and what changes does he look for? Well, that's a very interesting question. Mostly, when I see a patient with Parkinson's syndrome, I kind of explain in general what I'm looking for. So when we ask a patient to put his arms out, I'm looking to see if there's tremor with arms extended. When I ask a patient to do finger taps, I'm looking at the speed of the finger taps, the rhythm, and the decreasing amplitude. And when I have a patient do back and forth movements, again, I'm looking for rhythm, speed, and amplitude. Now, what do we learn from that? Going back to, say I ask someone to go back and forth like this, usually on their lap. Typically, that's not abnormal in Parkinson's disease, but is grossly abnormal in people who have cerebellar disease. So they can't do it with normal rhythm. In Parkinson's disease, it may be abnormal in the sense that they're slow in the movement. Very slow and very small amplitude. Instead of going like this, they may go like that. So I'm looking for the cardinal signs of Parkinson's disease, which is slowness of movement, especially in that movement. And then I'm looking for rigidity, but that can only be detected by manipulating the arm, the leg, the wrist, the head, to see if there's resistance to movement. There's another interesting thing we learned by the rapid alternating movement. When I ask someone to imitate the movement, rapid alternating movement, and they do this. And I said, no, like this. And they still go, they act confused. What does that tell the doctor? It tells the doctor that there is a cognitive problem. It isn't a motor problem. They can't seem to imitate the movement. So many people that I come across in the movement disorder clinics may have that difficulty in doing the rapid alternating movement. And generally what they have is a dementia. And they probably have either Alzheimer's disease, or they have dementia with Lewy bodies, or they have another variation of Parkinson's with dementia called, it's a mouthful, cortico-basal ganglionic degeneration. That just means dementia with Parkinson's disease that isn't, with Parkinson's syndrome that isn't really Parkinson's disease. So we learn a lot just from those simple things. So that's what we're looking for. Does the ability to perform these simple finger taps, rapid alternating movements, finger to nose, but why do we do finger to nose, this thing back and forth? Because a very common movement disorder that a lot of general practitioners call Parkinson's disease is really essential tremor. So when someone goes like this, then I know it's not Parkinson's disease. If it's just a rest tremor, they're sitting, the hands on the lap, and they have a rhythmic motion, and then they put the hands out, and it's slow, and it stops, and may come back later. That is seen in Parkinson's disease, but someone with essential tremor, they have no tremor at rest, they put their hand out, and it's like this. And if they do finger to nose, it's like that. Someone with Parkinson's disease on finger to nose will just do slow, without any tremor. So tremor that gets worse with activity, with action, is not part of the tremor of Parkinson's disease. So that's why we do those little manipulations. Every neurologist has a slight variation on how they do it. So how do you score this? You score it using what's called the Unified Parkinson's Disease Rating Scale. In every single movement that we ask you to do, there's a 0 to 4. with 4 being the worst. So with cogwheel rigidity, if I move your arm back and forth and I detect 0 resistance, in other words, it's very loose, you get a 0. If the resistance is so severe that I can't even extend the whole arm, it's so stiff, that's a 4. And between 0 and 4 you have, and so it's a subject, it's a call. I mean, and we kind of calibrate each other by looking at a video that asks us to calibrate, you know, how would we rate this tremor? Is it a 1, is it a 2, is it a 3? So intermittently we have these online courses. For anyone who does research with Parkinson's disease, we need to use the Unified Parkinson's Disease Rating Scale. So each of these movements and manipulations has a score. Now, when you see someone in the clinic, you're not in a clinical study, there's no need to put numbers to it. I do describe it as mild, moderate, or severe tremor, so forth, instead of using a number. So when I dictate the summary, well, I have a good reminder to myself or to other doctors what the extent of rigidity, extent of slowness. And when, you know, the interesting thing is that a lot of doctors in the community will just diagnose Parkinson's disease by having you walk up and down the hallway. And there's no really good rating of that other than to describe it as either narrow base, small steps, decreased arm swing. So, but why do we do all of this? And everyone who's seen a neurologist has some of this being done. Because what a neurologist is looking for is whether there's slowness of movement, whether there's rigidity, whether there's tremor, and what is the cognitive function like. So that's the one question. Here's the next question. My husband is always very hungry. He eats so much and is still very thin and still losing weight. Is this a side effect of a drug or Parkinson's disease? So it's a curious thing, but indeed, people with Parkinson's disease tend to gradually lose weight. And it just seems to be part of the illness. It's not like a severe weight loss, but it's not too common to see obese Parkinson's disease patients. Every now and then we see some very, very heavy people with Parkinson's disease. And typically those people don't really have classical Parkinson's disease. They may have, for example, diabetes, hypertension, and have a vascular Parkinsonism. And it's not really the same thing. But in general, people do lose weight. Some of the problem in really advanced cases is that it's hard to swallow, there's choking, so they're having a lot of trouble keeping their caloric intake up. This is really advanced illness though. And then drugs generally don't make you lose weight. Initially when dopamine agonists or levodopa is used, they can cause some nausea, and so people lose their appetite. And so they may have a decrease in food intake because of nausea, but very soon people become tolerant and adapt to that effect of the drug, and then they get over the nausea and decrease appetite. So in brief, yes, people do lose weight with this illness, which according to the media, you know, people always want to be thinner, but yeah, I don't think it's a good idea to let yourself lose too much weight. And a big complication about this weight loss is then a lot of people say, well, how can I increase my body weight? Can I take nutritional supplements like Ensure and Sustacal? Well, you can, but there's a big problem that I see with that is that those have a large amount of protein supplementation or amino acids in solution, which is very, very good for your health and building up your muscle mass. But they interfere with levodopa transport from blood to brain. So if you're going to use Sustacal or Ensure, have a can of it maybe before you go to bed. If you take it around supper time or lunch, the effects of Cinnamate may be diminished. That wasn't part of the question, but that goes along with this whole issue of weight loss and what to do about it.
Is muscle mass also lost?
It is, if in part because of decreased activity, decreased exercise. So it's another important thing we always talk about is keep active, keep up with exercise programs. Here's another question. This is a long one. It says, I'm a 70-year-old male who was identified with Parkinson's 20 years ago. I'm currently taking PD medications 5 times during the day and twice at night. I recently began experiencing periods of wearing off that follow a pattern. I usually begin to sweat. I feel hot. My breathing becomes shallow. It's difficult to catch my breath. I feel a crawling sensation in my extremities and tension in my body. There's usually no pain involved, but rather a generalized ache. The frequency of these episodes may be as many as 3 times per day and may last from 10 to 45 minutes. Intensity ranges from I can bull my way through this to I'd better sit this one out. Does this sound like a typical wearing off, or is this something I should pursue further with my neurologist in Illinois? I'm a snowbird. So, well, that's the problem. You're a snowbird. That explains it all. No, but to be serious, that is a really good description of a non-motor fluctuation, symptom of fluctuating of wearing off. Usually when we ask you, are you wearing off? If a person doesn't know what I'm talking about, they're lucky, because it means that the medicine they're taking is acting throughout the day, and when it's working, they don't know what it means to be off. In the early stages of the illness, just need maybe 3 tablets a day, and there's no kind of loss of effect of the medicine between the doses. But as the illness advances, after maybe 3 to 5 years, that 3 tablets a day doesn't carry you through. So if you take it at breakfast, by around 10 or 11, you're dragging, you can barely get up, your tremor's worse again. That's what I mean by being off. That's what we want to know. Some people wake up off. People who wake up on, in other words, they wake up, they don't even have to take their medicine to get up. Those are great, because that means it's still early in the illness, they're making enough of their own dopamine during the night. But as the dopamine synthesis capacity decreases and the number of dopamine neurons decreases, one wakes up off, takes the medicine works within an hour, let's say, and then gradually wears off by the 2nd and 3rd hour, and they need their next medicine. Ideally, we don't want them to experience that wearing off. So you know what on and off means. So the off usually refers to the motor symptoms. You're slower, you're more rigid, the tremor is worse, it becomes harder to get up. When you're on, you can get up, you can walk, you have less tremor, you have less rigidity. That's what on and off is. Gradual wearing off is due to the fact that you do not store dopamine anymore in your neurons because you've lost so many. So that your response to the medicine depends on how long the medicine stays in your blood. It stays in your blood 2 to 3 hours. That's how long you'll be on. So there are ways to prolong the on time, right? By inhibiting the breakdown of levodopa. That's why we use Comtan, or Stalevo has Comtan, etc. But there are other things that people have complained about that aren't those motor off signs, and those are the non-motor off signs, and those are kind of feelings of discomfort, sometimes anxiety, and you know that you're about to have an off period, a physical off period, a motor off period. But sometimes people can get really sweaty, really hot, feel this diffuse discomfort. It's a very unpleasant sensation, and that fluctuates in parallel to the circulating levels of levodopa. So yes, it's not an unusual symptom. It's something that can be prevented by, I would say in this case, using a long-acting dopamine agonist, such as the Nupro, which keeps constant blood levels throughout the 24 hours, and then you replace a patch every day. Then you'll never experience such severe waxing and waning of benefit of the drugs. And that patient shouldn't experience the sweating or the discomfort that he's described very well. He's obviously very self-observant, but if you really get to it, a lot of people that I've seen have these non-motor signs, and they're mostly symptoms, because maybe I can see them sweating, because I can see it, but it's mostly something they feel, they experience, and it's very uncomfortable. And they may not have that much of a physical off. They may have mostly this really unpleasant sensation. This leads to the tendency to over-medicate, because if you prevent those off periods by taking more medicines, well, that's the reason that you take more medicine, and then that can cause more problems. Here's another one. Okay. How are Parkinson Place, the Parkinson Research Foundation, and the university linked? In me. They're all linked in me. No. But that's the simple answer. The real story is historical. The Parkinson Research Foundation was founded by Larry Hofheimer. I don't see him here this morning. And it was founded many years ago, I'd say at least 10 years ago. I can't remember the exact date. And I became involved with them as someone who provided a newsletter called Parkinson's Update. And then when Abe Lieberman, who was the medical director for the Parkinson Research Foundation, left to go to Arizona to be in charge of the Muhammad Ali Parkinson Center, they asked me to be the medical director. So medical director, in the days that I started as medical director, involved my doing the newsletter, being available for educational conferences, and reviewing grants, because in those days we would provide a number of grants for interesting research projects. Parkinson Place is really new, and Parkinson Place is a brainchild of Marilyn Tate, working and talking with Larry Hofheimer. And if anybody knows what Parkinson Place is, you do, because you're here. And what does Parkinson Place? It's geared to the patient. Unlike what Parkinson Research Foundation, which was the startup, and that's really the central organization, that originally was to support research, and it will be again if we ever can get some Bill Gates to give us some money and support it. But right now we don't have the funding to support research projects, and that's what I would really like to see. We'd have to compete with Michael J. Fox. But what they're doing with the money that they do raise is running Parkinson Place, which I think is a unique place in the United States and Canada. There's a lot of people interested in visiting us to try to set up similar facilities in other states and in Canada. In fact, last week there was a colleague who came and has a donor who wants to set up something like this in Alberta, in Canada. So that would be really good. How is the university involved? Well, the university is who really is my boss, in that I'm a professor in the Department of Neurology, and I have an endowed chair for Parkinson's disease research called the Helen Ellis Endowed Chair. That gives me money on an annual basis to make sure I can have time to do research. So 80% of my effort is research. 20% has to do with patient care. And so as we started Parkinson Place, we were, Larry and Marilyn said, it would be really good if you could do something and see patients, not just talk to them. So then we started a Wednesday afternoon clinic. That required the university to sign a contract to allow me, because they own me, right? They don't own me, but all of the billing and scheduling and things, I have a contract with the University of South Florida Physicians Group. And they cover my malpractice insurance. They have all the financial kind of backup for being a physician. Parkinson Place didn't have any of that. So we have a contract with the University of South Florida and Parkinson Place that allows me to spend time seeing patients. The scheduling is done through the university in Tampa, the billing, etc., and my malpractice is covered through the university. So that's the relationship between the university, Parkinson Place, and Parkinson Research Foundation. Here's another. Currently, I am taking 1 milligram of Azilect. Will marijuana in pill form be harmful? I don't know why. marijuana is always brought up. I guess it's all the hippies have grown up and developed Parkinson's disease. But, well, there's no marijuana in pill form, at least in Florida. Marijuana doesn't come in a pill. What comes in a pill is delta 9 THC, which is one of the components in marijuana that has been approved by FDA for glaucoma for 30 years. So THC, also known as, I'm blocking it, Marinol. Marinol is the brand name for a pill that has an active agent that is found in marijuana, and it's allowed to be used for glaucoma. It saved a lot of people from going blind, and it's a pill form. 2.5 milligram oily capsule, or 5 milligrams. However, in the United States and in most parts of the world, well, in the US, FDA-approved drugs for one indication can be used by a physician in his judgment if he thinks it may be useful in another indication. So this Marinol can be used for specifically other problems. For example, I've used Marinol in patients with Tourette's syndrome. I don't see very many of them, but Tourette's syndrome is one in which they have a multifocal tics where they'll just all of a sudden toss their head, roll their eyes, and curse really loud. And they get in a lot of trouble because of their obscenity. They use really foul language, scatological language all the time, and it seems like they're really angry, and all of you just have this built up of the need to emit a motor jerk. It can be any kind, facial grimacing, talk. So it usually starts in childhood and continues throughout life, and it waxes and wanes. And the typical treatment is an agent that would block dopamine receptors, because blocking dopamine receptors slows all movements. Blocking dopamine receptors with a drug slows all movement. That should ring a bell, because you don't have enough dopamine in your brain, and that's why you have slow movement. But if you give a drug that blocks dopamine receptors, you can treat disorders of the brain that have too much movement, like Tourette's syndrome. But to give drugs like that block dopamine receptors, those are the major tranquilizers like Thorazine, Haldol, Pimozide. It slows people down, and they don't like the feeling of being slow and rigid. So you can use an alternative, which is Marinol, for Tourette's syndrome. However, if you use really tiny doses of these dopamine receptor antagonists in people like Tourette's, I'm giving an example where I might prescribe Marinol. I've never prescribed Marinol for Parkinson's disease because it lasts too long, it's very sedating, and it doesn't have that much benefit for the motor symptoms of Parkinson's disease. So, no, I don't recommend a pill that contains delta 9 THC. It makes people very spacey, a bit, it can cause a lot of things, short-term memory issues. I'd rather not have my Parkinson patients experience that. However, there are forms of cannabinoids that will be available sometime in the future that don't have so much delta 9 THC. They have a mixture of them. One of them is called cannabidiol, which is neuroprotective and toxidative, and might be something that could be given to Parkinson's disease patients to slow progression. But for now, I say don't take marijuana in a pill, which doesn't exist, or even Marinol. And it doesn't interact with Azilect. I just don't think it's a good idea for Parkinson's disease to take such a potent form of delta 9 THC. Next question is, okay, this one I hadn't seen. That's another one that just came today. I have an appointment for an assessment. I had cancer, and the drugs that I took caused me to lose heart function, which in turn the doctor says caused the Parkinson's symptoms that I have. Shaking left hand and arm, balance problems, and I'm just tired all the time. I don't see a question here. Anybody see a question in this statement? I'll be able to address, this is the kind of thing that can't be answered. I'll read it again, see if you can see a question in the statement. I would like to have an appointment for an assessment. Well, what I can suggest is you contact Tony and set up an appointment. I had cancer, and the drugs that I took caused me to lose heart function. Another statement, no question. I'm not sure what he means by heart function. Does that mean developed an arrhythmia? Did he or she have a heart attack? Did someone have collapse and have decreased blood flow to the brain? If so, if you had a cardiovascular collapse and you were comatose and you were resuscitated, if there's enough hypoxia, then you can develop a movement disorder. But it's usually not Parkinson's-like. Certainly you can develop a rigid akinetic syndrome, you can develop involuntary movements when you recover from anoxia. In other words, no oxygen to the brain. And then shaking of the left hand and arm, balance problems. Now, shaking of the left hand and arm, balance problems, and I'm tired all the time, might be Parkinson's disease, independent of his cancer and the drugs and the cardiac problem. So there was no question here, but I kind of filled the spaces between the statements. Here's another one. This is actually the way it is in clinic. People will come in with kind of a number of statements, and I have to make sense of it. And I think we could make sense of that. It seems confusing at first because it's not clear what heart function means. It doesn't, the doctor caused the problem, the Parkinson's symptoms that I have. So, well, doctors do cause Parkinson's syndrome all the time. Mostly psychiatrists who use, no, it's true. I mean, psychiatrists use major tranquilizers. And major tranquilizers block dopamine receptors. Blocking dopamine receptors make you have slowness and rigidity in Parkinson's syndrome. So yeah, it's very common. Now that we have new tranquilizers that don't block dopamine receptors, that is quetiapine or Seroquel, that many of you may have received from me because it's a fantastic way to improve sleep and protect against hallucinations and so forth. What was the other question? Here's another one. Is there a relationship between low blood pressure and Parkinson's disease? If so, should it be treated? And the second, how does stress affect Parkinson's disease? So I'll do the stress affecting Parkinson's disease. Stress amplifies the signs and symptoms of Parkinson's disease. It's been known from the very beginning, since 19th century, that when people were stressed, the symptoms were really bad, and when they weren't stressed, the symptoms were better. That relationship of stress increasing the expression of the illness is what accounts for the idea, the observation, that individuals who've been in a terrible stressful situation, it could be due to surgery they just had, financial collapse, divorce, moving, or having an accident, a car accident. And when they're examined, they're found to have some signs of Parkinsonism. I tell this story a lot. There was a woman whose husband died suddenly. During the funeral, she was noted to have some tremor of her hands. She was tremulous in general. She was very upset, clearly. And she saw her primary care doctor about a month after because she still had this tremor. And he sent her to me. I examined her and found that not only did she have a rest tremor more on one side than the other, and she had cogwheel rigidity, and she was slow with her finger tap, and that was it. So I said, you have early Parkinson's syndrome. I don't think you really need anti-Parkinson's medicines yet. And she said, well, do you think that stress could have caused this illness? I said, the illness was there even before your husband died. It was under the radar. It was like the iceberg under the water. It was, the radio was on, but the volume was low. And when you have this stress, up goes the volume. All of a sudden you hear the unpleasant music. All of a sudden you see the signs and symptoms. The fact that emotional stress can do this, as well as physiological stresses, is quite interesting, because if you suddenly have a decompensation in signs and symptoms of Parkinson's disease, and you have not done anything different with your medicine, look for some kind of stress that has caused it. Typically, it's going to be a bladder infection. It's amazing how often that's the case, because people tend to have problems completely emptying their bladder when they have Parkinson's disease, and so they're more prone to have bladder infections. When you have a bladder infection that you haven't been paid too much attention to, when it gets bad enough, it causes a stress. It's called physiological stress that makes your symptoms amplify. Doesn't mean that the disease is advanced suddenly, because the disease does not advance quickly. It's a very gradual, progressive illness. So if you have a sudden worsening, I question the presence of stress. Either you just had you have a bladder infection, you have a pneumonia that hasn't been picked up yet, or someone in your family is getting a divorce, or the stock market's plunging, or something, you know. So that's the stress story. There's another story about stress that's quite fascinating. In the 19th century, the fact that some people could walk and function normally, and other times that same person just was immobile and they'd be there with tremor and rigidity, led to the concept that this whole illness is due to an emotional problem. That there's nothing structurally wrong with the brain, because you can see the person walking normally, and other times they were not able to walk. So this doctor named Charcot, French neurologist, said there must be a dissociation between will to move and the motor apparatus of movement. There's a block, and that's what a neurosis is. So it's considered to be an emotional issue. And the fact is that wasn't true. It's actually a neurochemical imbalance. It's not enough dopamine that interferes with the execution of learned motor programs. And at times, that motor function is okay, at other times not, especially in the early stages of the illness. So now you know that emotion, stress, physiological stress can worsen symptoms, that the illness is not a neurosis, it's not a psychiatric condition, it's a neurological condition associated with problems in dopamine transmission, and now we know with other neurotransmitter systems. That's why gait and balance is such a problem, because it doesn't really improve very much with dopamine replacement. The other part of the question was, is there a relationship between low blood pressure and Parkinson's disease? And that's a good segue from what I just said. In addition to losing dopamine, which has several really critical roles in our brain, one is for the automatic execution of movement, and the other is for feelings of well-being. And whenever we experience pleasure, there's dopamine is being released in a different part of the brain, the emotional part of the brain. So that there are issues of difficulty experiencing the pleasure in the way that you used to. There can be depression as well, and apathy. Nothing really turns you on. You don't want to do anything. You withdraw. So those are due to not only just dopamine loss in the nigrostriatal system, but dopamine and serotonin problems. But there's another system that's involved called the norepinephrine system, which is, norepinephrine is a cousin of adrenaline. And adrenaline, you know, is released when you're suddenly frightened or ready to fight, or something, dangerous situation. It's released from the suprarenal gland, circulates and gets your pupils big, gets your heart rate pumping, increases your blood pressure, gets you ready to fight or flight, to either run away or protect yourself. And what happens, that adrenaline has that's an endocrine type, it's a hormone. But noradrenaline is a neurotransmitter. It's a cousin of adrenaline that's made in certain neurons in brain and in the peripheral autonomic nervous system. And what noradrenaline does the same thing as adrenaline, but in a very focused way. So noradrenaline is what speeds up your heart rate. And that's what if you're excited about something, just the noradrenaline of the sympathetic nerves will speed up your heart. It's noradrenaline that keeps the vascular tone of your carotid arteries and your arteries tight, so that when you lose noradrenaline, which happens in Parkinson's disease, there's a tendency to have lower blood pressure, lower heart rate, and inability to compensate for changing posture. So when you go from sitting to standing, normally the sympathetic nerve, the noradrenaline, causes the artery, the major arteries providing blood to the brain, to constrict a bit to maintain the blood flow. So the blood flow to the brain is decreased when you stand up suddenly. It could happen to even healthy people if they're in the hot sun and they're dehydrated. But it happens very frequently in Parkinson's disease. So in Parkinson's disease, because of the involvement of the noradrenergic, noradrenaline-making neurons of the autonomic nervous system, people tend to have low blood pressure. They also have this issue of feeling hot and cold and sweating, because that autonomic nervous system is involved with that. So yes, lightheadedness is common in Parkinson's disease, and many people who had high blood pressure may need to gradually stop taking their anti-hypertensive medicines, because Parkinson's disease is curing you of high blood pressure. And finally, medicines that we take for Parkinson's disease tend to lower the blood pressure more. So levodopa and dopamine agonists are notorious for causing drops in blood pressure. So getting up too quickly from the chair can really make you see what it's like to not have enough blood flow to the brain because of decreased norepinephrine and because of the effects of the drug. When it gets really severe, well, how do you treat it? Well, what you do is the opposite of what you do with high blood pressure. With high blood pressure, you tell people not to take as much salt. You give them a diuretic to empty the blood volume a bit to decrease blood pressure, and you give them drugs that block norepinephrine at the arteries so the arteries relax. So that lowers blood pressure. So many of the high blood pressure treatments involve those three types of drugs: avoiding salt, diuretics, and agents to relax the arteries. If you have the opposite problem, like in Parkinson's disease, you start telling people, take salt in your diet, eat salty food, raise blood pressure, stop your antihypertensives, start wearing TED hose to prevent pooling of blood in your extremities, and then if necessary, we give you midodrine that causes, or Florinef. Florinef increases blood volume by holding on to salt, and midodrine causes constriction of your arteries to keep the blood pressure up. So when this blood pressure issue is really out of proportion, really out of control, in other words, there's problems with maintaining blood pressure, just sit up and you feel like you're going to pass out. Blood pressure drops 30 points when you're going from sitting to standing, and you have a lot of problems with constipation, bladder, and so forth. That is called Shy-Drager syndrome. They have Parkinsonism, but the loss of noradrenaline is really pretty severe, and it kind of, as a concern, is more of a concern than even the slowness and rigidity. I think that covers it all. We have room for a few more questions, or follow up on these if you like.
Last night I was watching TV, Channel 9, the news, and the announcer comes up and says, we have Dr. Hauser.
Do we have another mic?
Hauser, yeah.
Was come up with some kind of idea to channel viruses in the brain so it can control the movement. Have you read anything about it?
Well, that's not Hauser's idea. The idea of using viruses to carry in genes into the brain it's an old thing. And there's a lot of studies that have shown that if you put a DNA, a gene for, let's say, 2 or 3 different growth factors, BDNF, GDNF, which we know enhance sprouting of dopamine neurons. If you put those genes inside a virus and then stereotactically implant them into the striatum on both sides, in monkeys, right, there's an increased sprouting. In humans, they've done these injections in phase 3 trials, and it's been a failure. So I don't know what, but that's one of the approaches. It's called the gene therapy approach. And how do you get genes into the brain requires a viral vector. Because there are viruses that are gutted, in a sense, but those viruses like brain cells. But to get them into the brain, you have to have surgery. So it's not, you know, it's something that is interesting from the point of view that we know that growth factors put into the brain will then slow down progression of the disease. But you can have those same growth factors produced normally by just exercising 4 times a week, cardio aerobic exercise. And finally, there's going to be a new way to deliver genes into the brain through the nasal insufflation method, you know, through spritzing it through the nose. Even though your sense of smell is diminished, the nerves that carry the information from nose to brain is still intact. It's just that your ability to distinguish smells is decreased. So yeah, I don't know what to make of it, but you know, that was local television. And Dr. Hauser's a clinical neurologist. He doesn't know much about basic research, so, but he might have been with a group. I don't know. I wish I had seen it. Then I could. What is it?
Pro-Savin. That's what I heard.
Well, that's an interesting. That is not a virus, as far as I know, and that is the other approach is to give a drug that gets into the brain that stimulates growth factor production. So, I'll look into it, but and these kinds of things are a long way from really reaching use in patients.
Could you tell us a bit about what you consider to be the main branches of fundamental research on Parkinson's?
Oh, that's a serious question. What are the main branches of basic or fundamental research about Parkinson's? Well, we can start at many levels of the nervous system, but one of the really hot areas is pursuing the molecular genetics of hereditary Parkinson's disease. Now, many of you have heard me talk about alpha-synuclein. That was the first genetic mutation that was identified with hereditary Parkinson's disease. But there are 12 different genetic mutations that are associated with markedly increased risk of Parkinson's disease. So what people are doing at a cell culture level and at a really fundamental level is inserting those genes that have been identified through pedigree studies into either cells or animal models and seeing how that gene can lead, how that mutated gene product can lead to the loss of dopamine neurons. And by doing that, one can illuminate some of the fundamental processes that lead to the demise of neurons. So that kind of work with alpha-synuclein, which was the first mutation, has led to the fact, by developing antibodies to alpha-synuclein, that the Lewy bodies, which are rich in the mutated alpha-synuclein, are distribute gradually throughout the whole brain, and that the spread of the disease is very much like the spread of prion diseases, or like what the so-called Kuru or mad cow disease. So that's one of the areas people are now investigating, how Lewy bodies can be transmitted from the olfactory bulb all the way to the midbrain, or from the midbrain all the way to the cerebral cortex. So that's fundamental research. The other level of research then is within cells. It's cellular biology. And we know that in neurons, that mitochondria, which are the energy warehouses, the energy furnaces, let's say, of every cell, where fuel is burned and energy is made to keep all the life processes going. Well, there's a problem in mitochondria in Parkinson's disease. They don't generate the ATP, which is the unit of energy exchange produced in cells. It's like the dollar, you know. With the dollar, you can do all kinds of things. And ATP is like the medium of exchange in cells for getting things done. You know, so in the process of not making enough ATP, there's also a production of superoxide anion and oxyradicals. And so the combination of not enough energy and too much oxyradicals results in the death of neurons. So then people have focused within mitochondria, what are the signaling elements that are involved in that kind of tell you the cell's going to die. And so they know that there's a cytochrome C release from the mitochondria into the cell. They know a lot. So there's a lot of research going on to the process of cell death in dopaminergic neurons. And by understanding the sequence of events, there's a cascade, one can intervene. So now there are people studying cell death and ways to interfere with cell death. So we call that anti-apoptotic approach. Apoptosis is the programmed cell death. that happens in neurons. There's another way that cells die, which is very quick and sudden. It's messy. That's usually following an infection or trauma or a hemorrhage. But the cell death that occurs in Parkinson's disease is very gradual, it's very tidy, and it's a programmed cell death. Programmed cell death is just part of human biology. For example, when the nervous system is being developed, we have a lot more neurons and cells than we really need, and they're gradually pruned away as you develop. And they're pruned away by cell death. If you look at how the hand develops, initially it's just one pad, one limb bud. And then the space between the space between the fingers, there's cell death. It's almost like you're a sculptor and you're gonna build a hand. You build up the clay limb bud, it just looks kind of like a Mickey Mouse, and then you cut out the spaces. That process of cutting out is called apoptosis. And apoptosis happens in the dopamine neurons. And we're trying to figure out how to stop apoptosis precisely in those neurons that are dying by that process. There's another aspect of basic research that has to do with the astrocytes in the glia. One of the things that happens as neurons are gradually dying is that there's an activation of the brain's immune cells, microglia. The microglia are responsible for cleaning up the debris of the dying cell. That's why it's such a tidy process. And it's an inflammatory process. And there are approaches to try to selectively decrease the inflammatory molecules released by microglia that seem to hasten the progression of the disease. So there's a lot of work going on with the neuroimmune system. Then there's work on trying to clear Lewy bodies. Remember I talked about the Lewy body spread? That's the pathological hallmark of the disease. But there's a concept, since we don't have Lewy bodies when we're healthy, what if we can clear the Lewy bodies that are there? So there are vaccines that are being developed in parallel to the vaccines for amyloid, which is the hallmark of Alzheimer's disease. Now, it's a long way to go, in fact, but I should just mention that the PRF funded a study by a neuroimmunologist of developing a vaccine for the Lewy bodies. And it's quite interesting. There's a lot of work along that line. In the future, and I think it's a very viable way to really cure this illness, is anyone who has the very first sign of Parkinson's disease, or even better, we're going to be able to see it before the first signs. We can start treating them with a vaccine. Now, you don't want to treat everyone in the population like you would with measles, because there are deleterious effects to some of these vaccines. But ideally, one could be vaccinated in the future against the development of this kind of disease. So that's kind of the basic research in many ways. There's even more going on. For some of the genetic disorders, there's ideas of doing gene silencing using small interfering RNA. Or there's even gene splicing, where now there are zinc finger nucleases that allow you to snip out a bit of DNA. But that's really a way, it really is very fundamental. It would be a long way before it would be useful for Parkinson's disease. It would only be useful for those that have strongly genetically determined Parkinson's disease, which is maybe about 2% of the population. Some people say maybe more. So, one more question.
Yeah, you alluded to the fact that if you wanted to keep your Cinevet on an even level, you could go to the Nupro patch. If you didn't want to do that, what do you think about the ER Cinevet? If that's what it's called.
What I alluded to was that we want to have the dopamine, let me just clarify, the dopamine receptors in your brain have to be tonically stimulated. We don't want up and down levels of dopamine, and those up and down levels of dopamine in the brain are because there's up and down levels of levodopa. So one of the first approaches was to develop controlled release Cinemet. Now, controlled release Cinemet results in less fluctuations, but if you look at the levels of levodopa, they're just slower. It's like still waves in the levels of dopamine, but in levodopa regular, it's more like this, whereas with the other, it's like that. What we want is completely flat curve. And there's no orally active drug that can give you a completely flat level of dopamine agonist, dopamine receptor stimulation, other than two. One is a infusion into the duodenum through a pump of a form of levodopa, and that results in probably the most stable circulating levodopa levels, but it requires you carrying a pump with you, and you need to have an indwelling catheter into your intestine. It's not appealing. The other approach is a dopamine agonist that really releases the dopamine agonist at a constant level. And the reason that we knew that this is what we want to achieve based on studies that were done over 25, 30 years ago, where people who had motor fluctuations on regular Sinemet were brought into NIH. Dr. Thomas Chase, who some of you may know from the cruises, he's usually one of our guest lecturers. They set up people with an indwelling catheter into the venous system and infuse levodopa. You can only do that for 1 or 2 days because it's corrosive to the vein. But as they dropped the levodopa into the blood, and they took blood samples throughout the 24 hours, they could see that the levodopa was kept very constant. The only thing, and so the motor effect was, they were on the whole time. So that's when we knew that if we could provide a form of levodopa that could maintain levodopa in the blood constant, we wouldn't have these on and off fluctuations. And we wouldn't have the dyskinesias. Because the dyskinesias are believed to be due to the pulsatile stimulation of dopamine receptors, then it's not, then hit again with a bunch of drug, and then they're not. Another thing was learned by Dr. Chase's work at that time was that if the patients were given constant levodopa infusion for 24 hours, but then at noon we're given a protein meal, levels of levodopa remained the same in the blood, but they couldn't do finger tapping for an hour or two. It got real slow. And that's when we learned that the protein interfered with blood to brain transport. Remember, by giving the levodopa into the blood, you didn't have to worry about the mouth or the gut or absorption. We used to think that the meal interfered with the actions of Sinemet because of effects on the gut, on the absorption from stomach, intestine to blood. And that study where you gave levodopa, you bypassed the gut, gave levodopa, it was infused constantly, but then you gave an amino acid meal. They also did it with just plain different classes of amino acids, which are the building blocks of proteins. And when they use a class of them called neutral amino acids, which are very common, you see them in milk and in, of course, sustacal and ensure, you get a complete blockage of the motor benefits of that constant levodopa infusion. That's why we can definitely say that chronic maintenance of a dopamine level in the brain results in much better outcome in terms of motor function. It's hard to do that, even with the extended release, controlled release, and Mirapex, which is interesting, because that is not affected by food, because Mirapex is not levodopa. It gets across the blood-brain barrier easily, but it has a half-life. It goes up and down too. So the next best thing that, in my experience, to the Nupro patch, which is probably the best for maintaining constant levels of dopamine receptor stimulation in the brain, would be a Mirapex extended release. It fluctuates a lot less than controlled release. And probably a really good approach is the formulation of levodopa in a gel that they put into the jejunum, into the intestine, through the pump. But that, it's kind of an aggressive, I guess for people that have really severe motor fluctuations and can't tolerate the patch, then one could consider that. There's another approach that I use for people who are good at following directions. It is the liquid levodopa regimen, and there you sip levodopa throughout the day every couple of hours, and you prepare it by putting in 10 tablets of 2,500 Sinemets, about 1,000 milligrams, in a liter of water, and 1,000 milligrams of vitamin C to prevent levodopa from oxidizing. If you were to put levodopa in water, it would turn brown, just like peeling a banana turns brown. That's oxidation of levodopa, forms a polymer. So to prevent that oxidation in your liquid Sinemet, every morning you make a bottle of water with 1,000 milligrams of levodopa, 1,000 milligrams of vitamin C. You keep it in the dark, in an airtight, light-proof, because light will hasten oxidation of levodopa. And every time you take 10 cc's, that's, don't do this on your own until you talk to me, but basically you adjust based on how much Sinemet you're taking in pill, we would calculate how much you should sip every 2 hours. And that results in levels of levodopa that go like this. Not way down, up and down. So people that have really, usually it's young onset Parkinson patients that have really severe motor fluctuations, and for some reason cannot take Nupro. I've used actually been around a long time, the liquid Sinemet regimen. I think I'm going to end it there unless there's one more question. Then. Okay.
This may be a long one. Funding and ICD, how are they the same? Are they the same? What can we do about them? Where do they come from?
Yeah, well, that has to do with that other function of dopamine. When I started in my career, I started off as a pharmacologist who was studying drug dependence. And one of the things that we knew way back then in the 70s, that a drug that makes you feel good, you feel euphoric, usually results in a release of dopamine in the ventral part of the striatum. When dopamine is released in the dorsal part, that's nigrostriatal, that's important for movement. There are drugs that stimulate release of dopamine in both, and those are the amphetamines. So amphetamines make you feel good, and they also promote motility and movement. In fact, amphetamines, when they were first generated in 1930s, a whole series of amphetamines were made to open up the airways because amphetamines mimic adrenaline and noradrenaline. So, in fact, the story, according to Abe Lieberman, was that Adolf Hitler had Parkinson's disease. He documented it based on films and the development, and it was in his left side. He'd always make sure that the tremor was not visible, but there are some videos that you can see the tremor. His handwriting, gradually, when it got to his right side, you could see his handwriting was gradually micrographic. And he was treated with amphetamine, because amphetamine released dopamine, acted on dopamine receptors, and temporarily improved it. But amphetamine does some very interesting things. It gets to your question. It's the release of dopamine in the emotional brain, that part of the brain that mediates reinforcement or pleasure. When that's excessive, that causes a number of interesting problems. One is stereotypic behaviors. Stereotypic behaviors are repetitive movements with no purpose. And so amphetamines are known. If you give amphetamine to an animal, they start doing all kinds of weird stereotypic behaviors. Amphetamine abusers will start picking and doing stuff like that, and they pace, and they start doing things that have no purpose. They'll take apart a clock and never put it together. They'll get involved in taking apart machines. They pace back and forth. And punting is that kind of thing. You do things over and over, but you don't know why you're doing it. So that's, and then impulse, I see as impulse control. Well, that's another thing that happens with chronic levodopa use or dopamine agonist use. So impulse control disorders, and that's quite interesting because it's not clear. We call it dopamine dysregulation syndrome, both of these, where you're giving incredible amounts of dopamine stimulating agent, dopamine receptor stimulating agent that not only stimulate the motor part, but also the limbic part. And that limbic part leads to preoccupation, obsessive compulsive thinking, with sexuality, gambling, all of these things that make you anticipate, because how the essence of pleasure is the anticipation of the reward. And so when you have a lot of dopamine stimulating the mesolimbic dopamine system, some people, not everyone, they get into hypersexuality. All of a sudden they start going to porn websites, or they get into gambling, compulsive gambling, or they develop punting, just stereotypic behaviors. In other words, repetitive movements without any purpose. So yeah, that is a side effect of the treatment of Parkinson's disease. People without treatment, Parkinson's patients who don't get these dopamine drugs, do not develop those problems. So yeah, those are side effects, and we tend to think of them as psychiatric side effects. In other words, impulse control. You get the idea and you do it right away. Impulse control obsessive compulsive disorders, gambling, hypersexuality, punding, all of those are side effects of the treatment. Luckily, we don't see it in, at least, it's kind of embarrassing for people to bring this up, so they may be underreported in the clinic. But usually the spouse will want to talk to me about some unusual behavior going on. Sometimes, I can say this because I first learned of this a long time ago. There was one patient who was a well-known person in the community in Miami, and he developed a weird perversion. He would wear women's clothes in the presence of the house servants and things, and he never had done that ever before. And we lowered his medication, put him on Clozaril, and that all went away. Clozaril helps deal with some of these problems. So that was the first time I learned of it, that you can get some weird sexual obsessions. And unfortunately, this had been happening for some time, and they would have a hard time keeping any maids in the house because it was weird. I think I'll end it there.
Wasn't that terrific? Dr. Ramos is the medical director of the Parkinson Research Foundation and a member of the family, and he really makes a huge contribution here. Like we told you before, Dr. Ramos is director of the University of South Florida Parkinson Clinic that is here at Parkinson Place, right? So every Wednesday afternoon, he's here. He's here for you to see you if that's something that would benefit you, all right?